Good morning. First of all, I would like to thank Mohammed, Arnon and Thierry for the kind invitation here to discuss with you frailty assessment and adjustment of therapy. The question, of course, is then why to assess frailty in elderly patients, and I think the answer comes from this publication in the Archives of Internal Medicine, and it now has been scientifically proven that whenever you enjoy life, you will live longer. And although the painter of the first patients with multiple myeloma might have allowed himself some artistic liberty, I think it's clear from this painting that multiple myeloma bone disease precludes an enjoyable life and therefore will shorten life. And I think therefore also for the elderly and also for frail patients, it is important to control the disease. And the question, of course, is then, can we control disease with the current treatment strategies also in the very old patients? And certainly we do, because when you have a look at 3 randomized clinical trials in newly diagnosed patients and also in patients with relapsed refractory multiple myeloma, it is shown here that the addition of novel agents to a backbone of melphalan prednisone does also benefit the eldest patients above 75 years of age. Whereas you choose either thalidomide or lenalidomide or bortezomib, you see that overall survival is superior to melphalan prednisone, also in patients over 75. And when you look to patients who had refractory relapsed multiple myeloma and were treated with either pomalidomide in combination with low-dose dexamethasone versus high-dose dexamethasone, you can see from this slide that the median overall survival was 12.6 months as opposed to only 4.9 months in patients who were treated with pomalidomide dexamethasone in patients over 75 years of age. But these are patients over 75 years of age in clinical trials, and probably these patients will have a good performance status and won't be frail. So what about patients who are older in real life, not being included in clinical trials? And I think therefore the data of the IFM are very important, and I got this slide from Cyril Hulin, and it is shown that even in real life, when you look to patients over 75, they have a comparable progression-free survival as the patients who are between 65 and 75. So also in real life, the addition of novel agents do benefit patients over 75. However, when it comes to overall survival, you see here that the overall survival is inferior as compared to patients who were below 75 years of age. And probably the toxic side effect from the first-line treatment precludes second-line or third-line treatment, and that's the reason why the overall survival is inferior in patients over 75. Well, indeed, in this meta-analysis from European trials in whom patients were treated, especially with novel agents, and there were almost 1,500 patients, it was shown that whenever you experience hematological toxicity or you had to discontinue therapy because of side effects, your probability of survival is less. So indeed, that's the case, that might play a role in an inferior overall survival in those patients. And I think that highlights the need for specific tailored strategies for the elderly patients in which we maximize the tolerability of the treatment and thereby optimize the efficacy of treatment also for elderly patients. Well, how to optimize then the treatment for the elderly frail patients? The first question is, of course, are there tools available with which we can identify frail elderly patients? And when we have these tools, does frailty really affect the outcome of treatment? Because these were the elderly patients, but not specific the frail patients. And if so, what are the reasons for a less progression-free survival and an inferior overall survival? And then the last question, of course, is how to adapt then the treatment of frail patients tomorrow in general clinical practice when having these tools available. So the question is, what is the definition of frail? And that's rather difficult. Frail is especially not performance status, because when you look to patients with a rather normal performance status of 1 or 0, you see that there's a lot of impairment of geriatric assessments in these patients. So up to 50% of geriatric assessments are impaired in patients with a low or a good performance status. And also when you look to the instrumental activities of daily living, you see that up to 44% of patients with a good performance status do have an impairment in geriatric assessments when it comes to the instrumental activities of daily living. And even there were 15% of frail patients in those patients. So when frailty was then defined as 3 out of 5 criteria, so that's the classic definition of frailty in the geriatric surroundings. So it's weight loss, weakness, poor endurance, either a slow gait speed or low physical activity. So performance status won't help us to identify frail patients. So what about age? Well, frailty is not identical to age, and there are more examples of this, but when you look to approximately 900 patients being treated in EMN trials, you can see here that 9% of the patients who were younger than 75 years of age were found to be frail. And importantly, also the patients over 75, 43% of patients were found not to be frail. So age is not a good discriminator to identify frailty. So are there then better tools available to identify frailty? And yes, indeed, there are. It's important work from Antonio Palumbo from the Italian group, and they investigated in 900 patients from 3 international EMN trials in whom all the patients were treated with either bortezomib, lenalidomide or carfilzomib, and in these trials they performed the geriatric assessments. So they looked to the impact of age on the activity of daily living, like dressing yourself, to the instrumental activity days of living, like handling your iPhone, and they look to the comorbidities and they look to the impact of these factors on the outcome of the patients. Subsequently, they performed a multivariate analysis, and they included known risk factors like ISS, chromosomal abnormalities, and of course they also adjusted for treatment. And here you see the impact of the individual factors on the outcome of these patients, reflected by the hazard ratio here. And based on the hazard ratio, a score was appointed to these individual factors. And then subsequently, a risk stratification model was developed affecting the outcome of these patients, and it's depicted here. And frailty was defined as having 2 or more risk factors, versus unfit patients having only 1 factor, and fit patients having only having no factors. Then they looked in a separate cohort of patients. It was a subset of the same study. And in this subset of the same study, they indeed found that this frailty score predicts outcome. And not only the overall survival, as is depicted here, on which the frailty score was based, but also progression-free survival was found to be inferior in frail patients as opposed to the patients with an intermediate fitness or to the patients who were fit. And I think it's important to realize that whenever we talk about high risk in elderly patients, such a frailty score might be even more important than the chromosomal abnormalities or age, because this discriminates the outcome of patients even more as compared to chromosomal abnormalities and age. Probably we should combine all these factors, but it's important to realize that frailty does matter in elderly patients and when you're starting treatment, elderly patients. So what are then the reasons for an inferior outcome in these frail patients? And probably that is what I already stated in one of the first slides. It is because of the fact that there's more non-hematological toxicity in the frail patients, as is seen here, and also the discontinuation rate due to toxicity is higher in the frail patients as opposed to the other groups of patients. And as I showed in one of the earlier slides, we know that non-hematological toxicity and discontinuation rate is related to a worse outcome. So should we now implement this frailty score tomorrow in general practice? And if so, how we should implement such a score? And I think two questions are important to be answered before we can implement such a score. The first question is, of course, is this score validated in a different patient population? Patient populations from other part of the world, from another clinical trial. And fortunately, the answer since the ASH in 2015 is yes. And that's because of the work of Thierry, and yesterday he showed already the slides. What can be seen here is that they determined the frail patients from the first trial. You know that the first trial was a trial comparing lenalidomide dexamethasone continuously either 18 months versus MPT, and they used the 5QED score in order to extrapolate the activities of daily living in those patients and the instrumental activities of daily living, and so they could define the IMWG frailty score. And it was found that in all the patient treatment, in all the treatment arms, the number of patients who were frail was approximately 50%. And then they performed a separate analysis in those frail patients. And I think that's important because that's the first study looking to the frail patient separately in a different patient cohort. And again, frailty was found to predict the outcome in the first trial also. You can see here. Here you see the progression-free survival for all the treatment arms. So the treatment arms were all combined. Here you see the fit patient, the intermediate patient, and the frail patient. And as can appreciate it from this slide, the progression-free survival is inferior as compared to the intermediate fit patients, and the fit patients only 20 months median progression-free survival, as opposed to 28 months progression-free survival in the fit patients. And this does not only account for the progression-free survival, it also accounts for the overall survival. As you can see here, also the overall survival was even more inferior as compared to the fit patients whenever the patients were defined as frail. So the frailty score has now been validated in a different cohort of patients, and I think that's a very important step in order to implement such an IMWG score in clinical practice. Another important question, I think, is to realize that actually when you want to implement such a score in clinical practice, you should actually do risk-adapted randomized clinical trials investigating the outcome of treatment to see whether frail patients should be treated different as compared to non-frail patients. And you should design a study which, with a design like this. You take frail patients and non-frail patients and you randomize between treatment A and B, and then you can really define which type of treatment is best for frail patients. And actually, we don't have such clinical studies in order to guide treatment, and therefore the answer is no. On the other hand, it shouldn't be that when there are no clinical trials, we should not look further than what we generally know. And the question then is there circumstantial evidence guiding the treatment of frail patients beside the common sense? And common sense would ask, are 2 drugs sufficient for frail patients instead of 3 drugs? And there's several clinical trials investigating this issue, although not in a randomized clinical trial way. And I want to show you, because of time, only 2 studies showing some data, which is, I think, circumstantial evidence to implement this frailty score into clinical practice. Here you see a recently published study from La Rocca from Italy, and they compared 3 regimens. I think it's important to realize that it was a non-randomized trial. It were cohorts of patients, and some of these patients were treated with bortezomib dexamethasone, and then in other groups of patients there was either cyclophosphamide added or melphalan added. And all these patients received maintenance bortezomib on day 1 and 15 until progression. When you look to the curves, it's appreciated here that the progression-free survival is not really different, 14 versus 15 versus 17 months. Again, important to realize a non-randomized clinical trial, and also the statistical analysis was hampered by the fact that it was not powered, this study, to find a difference in the progression-free survival, but it looks rather similar. And also it can be shown here, it can be seen here, that the discontinuation rate due to toxicity was higher in the VMP arm. What they did was that they did a sub-analysis in the frail versus the fit patients, and what can be seen here is that in the frail patients there's a higher rate of severe adverse events. The dropout during induction was much higher. Also, the discontinuation rate due to toxicity was higher, and importantly, of the 6 patients who were dying during this period, 5 of these patients were found to be frail. Of course, when it comes to proteasome inhibitors, the dosing of bortezomib should be different, and especially it shouldn't be twice weekly, but once weekly, and that is because of the fact that when you administer bortezomib twice weekly in a frail population, the grade 3 and 4 neuropathy would be much higher, and that translates in a higher discontinuation rate in patients as opposed to only 5% of neuropathy in the patients receiving once weekly dosing with a lower discontinuation rate. And important to see is that it does not negatively affect the outcome when giving it once weekly. The only thing which is important to realize is that bortezomib was continued after induction therapy for either 2 or 3 years in order to get the same cumulative dose as compared to the classic VISTA trial. But it was possible to continue therapy because the discontinuation rate during induction was much less when you administered the bortezomib once weekly. So what about 2 drug regimens versus 3 drug regimens using an IMiD as a backbone? And here you can see from the IFM trial, and I got this slide from Thierry, thank you very much. And what you can see here, that when you look, going back, when you look to the progression-free survival in frail patients only, so this is in a subset of patients, you see that also in the frail patients giving a 2-drug regimen, lenalidomide, dexamethasone, until progression, that it was an improved outcome was found with RD as compared to MPT, and this accounted also for overall survival in these frail patients. So frail patients do benefit from a 2-drug regimen instead of a 3-drug regimen, and this is not on the slide, but also the Italian group compared RD with the addition of either cyclophosphamide or with melphalan, and they didn't find a difference in the very old patients between the 2-drug regimens and the 3-drug regimen. So there is circumstantial evidence to give a 2-drug regimen instead of a 3-drug regimen in frail patients. And therefore, I would like to state for tomorrow or the day after tomorrow or Monday that in clinical practice, the treatment for frail patients should consist of a preferably 2-drug regimen, either RD or VD. And because we think that alkylators might still be helpful, because when you look to the VISTA trial, it has a good progression-free survival. In the Netherlands, we are doing at the moment a HOVON trial with an adapted dose of MPV. And of course, there should be dose reduction of bortezomib and probably also of lenalidomide. Then the last 2 slides to emphasize that we're not there yet, because when you look to the frail patients, of course, they do have an improved outcome also with the novel agents, but still their outcome is worse as compared to patients who are younger. And so this indicates that with the frailty scores we have now available, or with the eyeball tests we use in clinical practice, we're not able to specifically define the patients who would benefit from even a more intense therapy, thereby improving their outcome, and they would have more benefit from some more intensified treatment, whereas in other patients we maybe should even not give treatment because we would hamper their quality of life and do probably harm. So we need better frailty scores in clinical practice. First of all, I would like to recommend this documentary. It's Gold Autumn, and it's on kind of geriatric Olympics, with the participants being up to 100 years of age, which is this man, and it's a very nice documentary. But what's also shown on this slide, that at the moment we are doing in our HOVON trials, in the elderly trials, also functional assessments. So not only the questionnaires which are implemented in the frailty score of the International Myeloma Working Group, we are looking to grip strength, like is here, and we're looking to gait speed, because these are probably very good indicators for frailty, and maybe even more better than the ones we have in the questionnaires, and hopefully we will be able to present some of these data next ASH. The other thing which might be very interesting is to look at biomarkers for frailty. And one of these biomarkers might be sarcopenia. The relative contribution of muscle compared to fat indicates whether there's sarcopenia or not. And it is known from, especially from solid oncology, that sarcopenia is related to a higher incidence of dose-limiting toxicity. And it really negatively affects the outcome of patients. And recently, a paper from our Department of Oncology in the VU Hospital showed that you should probably not look at one point, but also control during the treatment of the disease what's happening with muscle mass. Because when there's a decrease in muscle mass during treatment, which is reflected here, more than 9% of loss of muscle mass during treatment for solid tumors, it was observed that the outcome was inferior as opposed to the patients who did not experience muscle mass. So probably we need novel biomarkers. One step ahead would also be the senescence markers we can measure in order to really biologically define frailty. So I think there's still a lot to do for the myeloma community, and hopefully from the translational research group from the VU Hospital we can add to that. I thank you for your attention.